Well, hi everybody. Thanks for coming out tonight. I know some of you, but most of you have no idea who I am. So I'm Rayson. I'm a medical oncologist at the QE2. And some of you may not know what a medical oncologist is or what we do, but we're cancer specialists. Many of you are familiar with surgery for cancer. Those are surgical oncologists. Radiation for cancer, radiation oncologists. Medical oncology is involved with medical treatments of cancer, both in terms of trying to treat the disease with either medicines like chemotherapy or a lot of new medicines coming down the road that don't involve chemotherapy, but also in terms of treating symptoms that might be related to cancer and helping to control the disease as much as possible. So we all work together, medical, surgical, radiation oncologists, and we all have different roles to play in different diseases and with different people. So first of all, thanks very much for asking me to come out tonight, and we can make this as interactive as possible. I've got a very short presentation that really many of you I know are interested or have some experience with pancreatic cancer, but may have some questions about what this area is all about. And so I've actually tried to design this as 15 questions you might be wondering about in regards to pancreatic cancer. So we'll go through it, and if you have any questions, stop me at any time, and there'll be lots of time for discussion at the end, and we can keep this really informal, okay? Everybody okay with that? All right. So the first, what is pancreatic cancer? And this really applies to almost all cancers. So all cancers are really a collection of cells that start off in one place. We're talking about pancreatic cancer, so this is true for the pancreas, but breast cancer is similar, colon cancer is similar. It's an abnormal cell that either grows too fast, out of control, or it forgets how to die. Because remember, a lot of our cells in our body every day are living and dying at the same time. Cells lining our gut, our hair, our skin, our bone marrow, cells are constantly living. Babies are born, they live, they die, and there's a program that cells cycle through. So cancers happen when that program, when that normal process of cell growth and death gets messed up. And one cell is able to start growing uncontrollably and becomes a lump or an abnormality in a tissue. And so pancreatic cancer is really not that much different in that basic way from cancers arising in other parts of the body. So it starts with a single cell. Now, the pancreas is it's in the middle of the gut, middle of the abdomen, halfway between the belly button and the back. It's about as hidden as it gets in terms of body parts. Normally, the pancreas has two major jobs. It makes insulin, which, as you know, if that doesn't work very well, people can develop diabetes. And it also makes chemicals that get squirted into the gut that help us break down our food. So it's very important in terms of nutrition. So those are the two major jobs of the pancreas. And normally, it sits very quietly in all of us and doesn't cause any trouble. Pancreatic cancer, though, is very difficult to diagnose. And this is one of the major problems with this disease. It's very difficult to diagnose. It's very difficult to diagnose early. And the problem is location, 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 just like real estate. It's because of where it is, and it's completely hidden from view. And if you don't have any problems with your blood sugar, and if you're absorbing your food okay, nobody ever gives a thought to it. And I'm just going to show you how tricky it can be. So this gray fuzz here is the pancreas, and that darker gray fuzz is actually an abnormality in the pancreas, and that's a pancreatic cancer. In the same way as this gray fuzz is.
So is this a cross-section of the pancreas?
That's right. So these are CAT scans, and basically feet are here, the head is on the other side, and just imagine that I'm lying on a table with my feet towards you, and that table is moving slowly but surely through a circle. And that circle is taking pictures of me, slicing me like I'm a loaf of bread. So each of these pictures is a slice of me, of that bread. Do you know what I mean? So the question was, what are the arrows pointing to? So one of the areas here is exactly, Keith, pointing to the tail of the pancreas. And these arrows here, these two, are pointing to the head of the pancreas. And this one's pointing to a process called the uncinate process. So the pancreas kind of looks like a fist with a short arm sticking out the back. And that short arm is the tail, and the fist is the head. And cancers and tumors of any sort can happen at any place along that structure. But they grow quietly, silently, and they're hidden from view. And that's one of the big problems. Breast cancer, as you know, we have mammograms that can screen for breast cancer. It can pick up very, very tiny spots in the breast. Colon cancer, as you know, we can have a look up the bowel and really check the inside of the linings. We really don't have any of those tests for pancreatic cancer. And that's why it's so difficult to detect at a very early stage. So are all lumps in the pancreas cancerous? Absolutely not. And in fact, there are many lumps and many abnormalities in the pancreas that aren't cancerous. People can have cysts in the pancreas. They can have little growths, sort of like almost like little warts that come off the pancreas. They can have funny little curves in the pancreas. People who have episodes of pancreatitis, which is an inflammation of the pancreas, can have these strange looking types of growths off the pancreas. So there are many, many different things that can look abnormal on the scans, but have nothing to do with cancer. And it's really important for doctors not to always jump to the worst possible conclusion, because many times abnormalities in the pancreas aren't cancerous, but it can be very tricky to sort out which ones are and which ones aren't. So not everything that's abnormal in the pancreas is cancer. There are a lot of benign things, non-cancerous things that happen to the pancreas. But there are certain ways we have of seeing if a lump is cancerous. And really, I'm just going to go through these. These are the 4 big ones. So sometimes patients have a symptom, they get a CAT scan, and the CAT scan shows an abnormality of the pancreas. Sometimes a cyst shows up very clearly. That's a cyst, nothing to worry about. And sometimes it's not so simple. Symptoms, of course, are a big problem. The problem with the pancreas is it sits on top of a bundle of nerves. And if the pancreas gets irritated for whatever reason, whether it's an inflamed pancreas or an infection, there's a lot of pain associated with it because those nerves get irritated. So many times if patients have pain and have a scan like I showed you, that raises the concern 100-fold that this might be a cancer problem. Sometimes we see that there's abnormal invasion of other tissues around the pancreas or swollen lymph nodes. So there are some clues that the radiologists have that can say, you know, this doesn't look normal and we're worried about pancreatic cancer. And there are other times when it may not look normal, but there are none of these clues, and therefore people are much more relaxed about it. Any questions about all that? Okay. So this is a big question, because many times when you go online or when you hear about pancreatic cancer, many times it's thought of as just one disease with one outcome and with one pathway. Absolutely not true. Pancreatic cancers aren't all the same. And even among these different kinds of pancreatic cancer, the behavior of the disease, the behavior of the cells can be very different. The most common is an adenocarcinoma. Those are basically 90% of all pancreatic cancers. And that's just the name that's given to cells that make glands in the tissues. So breast cancers are called adenocarcinomas. Colon cancers are called adenocarcinomas. Not all breast cancers are the same, not all colon cancers are the same, not all pancreatic cancers are the same. There's a type that grow very, very slowly called mucinous adenocarcinomas, where patients can present with very, very big, scary-looking masses in the pancreas, but be perfectly fine and remain fine for years sometimes, even without any treatment, because the cells change so slowly and the body can adjust to them. There are rare tumors called neuroendocrine tumors that are the rarest of all pancreatic cancers, and those are totally different. The treatments are utterly different, and the pathway is utterly different. And we're smiling here because we have a great example of one of those. And they're completely different diseases. And sometimes there are other diseases called lymphomas, which is a cancer of the lymph glands, which can actually start around the pancreas, which again are totally different. And the only way to find this out is to actually look at cells under the microscope. So I think the bottom line that I think it's very important for you guys to know and for us to know as doctors, and whether we're cancer specialists or not, is that not all pancreatic cancers are the same. And we have to look at them very individually. So, and I'll have it here, just look at that last line. Tissue is the issue. And really, it's critically important. A biopsy is really the only way to be sure. And that's true for all kinds of cancers, unfortunately, not just pancreatic cancer. For instance, for breast cancer, as you know, many women do have a mammogram and then a biopsy under the mammogram. The problem with pancreatic cancer, and you can see where it's located, biopsies are tricky. There's lots of stuff in the way of a needle going through there. So sometimes a biopsy can be very difficult, but it really needs to be done, because otherwise you may end up with a wrong diagnosis and potentially a wrong treatment. There are other tests that we do to try and help us along the path to a biopsy. The various scans, and I showed you a couple pictures of those, and sometimes some blood tests that are out of the normal blood tests that can help us. But really in the end, without looking at cells under the microscope, it's very difficult to be certain as to what is truly going on. And especially to make sure that actually this lump that everybody's calling cancer, make sure it's not actually a benign growth, a non-cancerous lump, because that absolutely does happen. So the question was, and I'll just repeat for the video, is a biopsy something that should be advocated for to make sure of the diagnosis, even though, as you say, sometimes some patients or some patients you've come into contact with may be treated without a biopsy. So the bottom line is, yes, I would strongly advocate for biopsy, no question about it. Now there are some cases, so someone who is older, much older, very sick, where a biopsy is too dangerous. Some people who are on blood thinners, that need to be on blood thinners, where putting a needle into the space that I showed you would be too dangerous. So there are some cases where when a biopsy is too dangerous for the patient, sometimes we make a decision that given the whole constellation of evidence, we would still treat them as X, Y, or Z, but those should be the small minority. For most people who are fit and well, biopsy is really important. Before anybody really, really go. Now, surgeons may decide that this looks like pancreatic cancer in every which way we look at it, and we want to go and try and see if we can remove it all. So they may proceed to surgery without a biopsy, because they're going to be in there anyway if they're moving to surgery. And they'll make a diagnosis from a biopsy at the time of surgery. So there are some times when surgeons will operate without a biopsy, but only when it looks that they could actually remove the whole growth. And the question, sorry, just remind me to repeat, is a brush biopsy during ERCP as accurate as a needle biopsy? No. And it's not so much accuracy, it's the ability to pick up the disease. So most times brush biopsies will come back as negative. And with a brush biopsy, all you get are a few cells. which can be distorted, inflamed for whatever reason. With a needle biopsy, you get actually, under the microscope, it looks like a small needle, but under the microscope, there's a tremendous amount of tissue there. So, yeah, a needle biopsy is best. Sometimes we're limited to a brush because of technical and safety. The question is, what is a brush biopsy? So sometimes the bile system is like a set of plumbing pathways, pipes. And so sometimes a test is done where a scope is placed into those bile pathways to look at them. And you can take a small little brush in through the scope and just brush the sides. It's like cleaning, it's like a pipe cleaner. It's honestly not more complicated than that. And you just scrape the sides, pull it out, smear it on the slide, put it under the microscope. And the question is timing of surgery and outcomes, just for the camera. Really difficult to know, and that's just being honest with you. You know, unfortunately, one of the brutal realities of pancreatic cancer is that even when surgery removes everything, the vast majority of times there's already microscopic spread to either the linings in the abdomen or the liver. And that's why that many patients aren't candidates for surgery even when it's found early, because most times there is already spread around the area. The role of surgery really, and I'll get to this in a minute, but I'll just answer your question, is really designed for if there's a possibility of complete removal. And the problem is, even with complete removal, 80 to 90% of patients will have recurrence in other parts of the body. If there's an abnormality, really a biopsy is the only way to know for sure. It can be very difficult and challenging, and sometimes we fight with radiology and with surgery and with other people to get a biopsy done because they don't want to do it for a whole bunch of reasons. But it's becoming increasingly important for patients, no question about it. The question is, as a patient, can you insist on it? I think you can. I think patients can be very demonstrative, you know, by saying, you know, I am just not comfortable with this. I really, if it's, understand there's always limits to safety. Like nobody would do it if it's unsafe, if it's clearly unsafe. But a patient can easily say, look, if it's within the realm of safety for me, I really want a biopsy. I really want to know what this is, if I need to worry about it or not. So yes, a patient can advocate for it, but it's tough. It's tough to do. It is tough to do for a patient. It's a great, great point. Absolutely. In fact, you know, when we, as some of you who know me, work with Helen, my nursing colleague, we work as a team. And if we ever see a patient alone, our hearts sink, because we know that they're feeling vulnerable, terrified, really. We know that all of us, especially in times of these kinds of stresses, can only hear about 10% of all the stuff we're saying. That's just human nature. All of us are like that. And so absolutely having family members close who can, a different pair of ears, different pair of eyes, different mindset, is really, really helpful. So we'll oftentimes, if there's any confusion, if we get a sense from a patient that, you know, we're not sure where they're at, we'll oftentimes send them home and make it a quick follow-up appointment, insisting they bring other people with them. You know, we just won't get into details when it's just not right for them right now. So yeah, really important point. So you're right. Yeah, people don't have to be perfectly fit to have a biopsy, and now we have different ways of doing it. We've got a lot of support, a lot of ways to do it under CTs or things like that. So there are ways around some of the older issues with biopsying. Yep, good point. Tissue is the issue, no question about it. I mean, sometimes we just can't get there, but if there's a possibility to get there, we should get there for the patient. I'll just show you this, and it kind of comes to a little bit of your question, perhaps. And again, not to get into any too details, but I just want to show you, there is a series of steps that evolve towards pancreatic cancer. And again, I'm not going to go through these in detail, but the cells change. And there are some here, these slides show actually precancerous pancreatic cancer. evolving towards it. How long, I'm just going to ask you guys, would you estimate, as far as we can tell, it takes to go from here to here? 2 years. Any other just thoughts? It is 3 months. It probably varies for sure, but it's about 11 to 14 years. It's incredible. So it's very interesting what's evolved over time. It's a better understanding about pancreatic cancer. It used to be thought they were all very aggressive, growing very quickly, but actually most grow very slowly. But the problem is they grow under the radar for so long that they have time to. So again, it's a real eye-opener. It is scary. It's scary for everybody, but things can really go under the radar, and that's been one of the problems with trying to catch pancreatic cancer early. They grow slowly, they grow under the radar, they're hidden deep, and they have a lot of time to spread around. We've had a couple of cases. In fact, I have a colleague of mine in Montreal, who was the head of oncology in Montreal, who had some kind of weird stomach pain, thought it was a gallbladder, had a CAT scan, there was a funny little ditzel on the pancreas, nobody could figure it out. He said, I need to know. It was biopsied. He had one of these early things found by fluke, nothing to do with the symptoms, and actually had a Whipple's for prevention. And hopefully he'll be fine. But so rare as hen's teeth, but absolutely, yep. But it's usually because it's a coincidence with something else. Yeah, another symptom that has a scan that leads to further testing and diagnosis. Yeah. So breast cancer, just to clarify, so hereditary breast cancer, so where we find a genetic cause, actually only about 2 to 3% of all cases. So the vast majority of cases are not genetic that we can understand. Pancreatic cancer, there are about 10% of cases that are, quote, familial. So, and when I say familial, it means 2 first-degree relatives in a family, or 3 first or second-degree relatives. So when you start seeing even 2 cases within the same family, because it's not a common diagnosis, that raises a possibility of a genetic risk. There are a whole bunch of different genes that have been associated with this risk, but they're all associated with other cancers as well. So there still is not yet a very specific pancreatic cancer genetic test. But there's a lot of research right now in this. I think in time, I don't think general genetic testing the way we understand it. I think because genetic testing the way we understand it, we look for genes that get passed through the family, but we've got zillions of genes in our body now that interact with all kinds of different environmental things, and maybe by the time I retire, but probably even later than that, I'm no doubt there will be specific genetic tests for each one of us. Yeah, but it's a little bit in the future yet. There are a couple of genetic links between pancreatic cancer. So the one we oftentimes think about the most is pancreatic cancer and actually breast cancer, with a mutation called BRCA2. BRCA2, yeah, BRCA2 especially. There are reports of a link between pancreatic cancer and melanoma, but it's very poorly defined. So, well, we've covered a little bit of what is the role of surgery, and it's basically to remove all disease. But really, these are the 3 major bullets. One, as long as there's no spread, and unfortunately, because it grows under the radar, even microscopically, there commonly is spread to the other tissues. If it's technically feasible, so the problem with the pancreas where it sits on these nerves, it's wrapped around blood vessels. So many times, purely from a technical point of view, surgery is just not possible. And third, it's major surgery. It is not easy surgery. It's been described, Whipple's has been described as basically the biggest surgery one can go through apart from a full transplant. So the patient actually has to be able to tolerate it. So because of these 3 points, so few patients are able to have curative surgery. And it's because of these three things, nothing else. Sometimes we see patients before surgery with the question, well, there's this lump, we can't remove it now, technically, but maybe if we treat it with either radiation or chemotherapy or sometimes a combination, and if there's some shrinkage, maybe then. So that is possible. Unfortunately, it happens fairly rarely, but when it does, it's it's excellent. Although that patient will still remain at risk of recurrence, at least they have more of a chance of staying without the cancer. So sometimes patients are treated before surgery if their disease is on the fence as to whether or not it can be operated on or not. But it's pretty rare. Now, if surgery isn't possible, what then? And this is where we come in many, many times as medical oncologists. Because really, if we can't do complete surgery, the goals are really to control the disease, to turn it from a life-threatening situation into something people can live with. Hopefully live with well, with as few problems from the disease as well as the treatment for as long as possible. And it's really balancing that out. There's always a balance. Unfortunately, all our treatments can cause side effects. All our treatments can be difficult. We have to make sure the treatments aren't worse than the disease in front of us and try and balance that out for every single patient. And that's really where a lot of medical oncology comes in, is to try to find that balance if surgery can't remove everything. Sometimes that balance is very easy, sometimes it's hellishly difficult because everything we do causes tenfold more problems. And every single person's different. You know, I think you guys understand this, but I think it bears repeating that our genetics are different, our chemistry is different, the disease is different, the way we handle medicines are different. So I can give the same treatment to 5 people with the same height, same weight, same eye color, and I'll have 5 totally different stories. There's no way to predict. And that's some of the uncertainty with a lot of what we do. So what options are there to get that balance, right? To try and balance it out between the disease and side effects. So one option, and this sometimes doesn't go over well, is truly to monitor it. And it's a bit different from your mom, you know. But if patients are well and having no symptoms, and surgery isn't an option, so we know the disease is going to be there, many times just close monitoring and bringing in treatments when they are most likely to be of benefit makes sense because of that balance. The problem is sometimes things can happen very quickly in this disease, and sometimes patients can do well without anything and then very quickly become sick. And so again, it's all individualized, and patients have to be comfortable mentally with being observed or monitored, and some people just aren't, just for all kinds of appropriate reasons. There are all kinds of medicines we have to treat symptoms. Pain is an issue with pancreatic cancer. We've got lots of options for that. Sometimes we recommend nerve blocks. Remember, the pancreas sits on that nerve bundle, and we can freeze that nerve bundle just like the dentist freezes our nerves to get our teeth out. And so that can be done. Because the pancreas is involved in nutrition, there can be weight loss, malabsorption of food, and we've got different stimulants to help with that, different things to help with absorption. So there are many non-chemotherapy ways we have of trying to improve symptoms. And those are all, again, individualized. And then finally, there's chemotherapy. Now, what is chemotherapy? Powerful medicines. Historically, I shouldn't say usually given intravenously, because a lot of times now they're not. They're given in pill form or sometimes by shots. But still, most of us think of chemo as intravenous, through a needle, right? And what chemo does, simply said, remember we talked about how cancer cells are programmed to keep growing and they forget how to die and they keep growing out of control, or out of the norm? Chemotherapy disrupts whatever it is that's stimulating them to grow. But the problem is, it does it to normal cells as well. Because all of our cells are constantly growing and dying. Hair follicles, all the cells lining our gut, the bone marrow. And that's why chemotherapy can cause so many side effects. Because it doesn't just interfere with abnormal cells, it interferes with our normal cells as well. But cancer cells, if you're able to get rid of them, they're not programmed to regenerate. Once they die, they die. Whereas our normal cells, that's part of what they do. That's why we need to keep getting haircuts. That's why we need, it's the growth cycle and the death cycle in our cells going on all the time. So cells are dying off and they're regrowing, dying off and regrowing. Cancer cells, if we can get them to die, they can stay dead. And that's part of the goal of chemotherapy. But why can't chemo cure pancreatic cancer? And it's really two big reasons. And really these are the two most important ones. The first, cancer cells learn. They are the smartest cells around. Even when things are going beautifully, they can learn to become resistant to whatever we give them. Or they can be resistant right off the start in ways we don't quite understand. And the other big problem is, even if one cancer cell survives, it will start growing and regenerating again. And a lot of our chemo treatments can't eliminate every single last cancer cell. And this is just a picture. This is actually what we call an electron micrograph. That is a single pancreatic cancer cell. Do you know how small a millimeter is? Okay, so think of a millimeter cubed. You know, it's a tiny little speck. There are a billion of these guys in that millimeter cubed. 1 billion. And so even if we get rid of 99% of them, there's still a lot left over to cause trouble. And that's, we keep hitting our head on that same problem. A couple of last slides, and then we'll just open up for discussion. Lots of new treatment options though. The first three are treatment options for typical adenocarcinomas of the pancreas. The next three are treatment options for neuroendocrine tumors of the pancreas. And the last one are treatment options for lymphomas from the pancreas. And again, I bring this up not to really go into details about the treatment of this disease, but just to show you again how important it is to make sure we know what we're dealing with. Because in 2012, we've got this number of options, and no doubt 5 years from now, we're just going to keep adding. There are a number of new options in trial. None of them are chemotherapy. They're all targeted therapy for specific either gene problems or alterations in the cells. There are probably about a half a dozen right now that are showing promise. But it's really important, guys. You know, there's so much hope for some of these medicines, and it's so easy to get hopes up. Unfortunately, in oncology, you know, to take a drug from a dish of cells into an actual trial that actually tests a treatment in patients can take 5 to 7 years. And a lot of times, a lot of the hype we hear are at the first stages of when there's some medicine that looks like it may have something, may help with a mouse's pancreatic cancer cells. It's a combination of things. The science has become a lot more complicated. The regulatory, so clinical trials, and this is the way we study these, is actually comparing treatment A to treatment B in a group of patients, are very heavily regulated and takes a long time to get through the whole regulatory process to even get them up and running. They are getting much more expensive. So it is a big issue. there's a real initiative now to shorten that timeline, that I think because people are getting impatient, everybody's getting frustrated with the whole process. So I think that is going to change because our trials are going to get much smarter. It's not going to take just 100 patients with pancreatic cancer. It's going to be very focused on the specific type of pancreatic cancer and the specific molecule. And so we'll need far fewer patients to see if something actually works. So things are changing, but it's slow. Abraxane? Yep. So Abraxane is a chemotherapy drug. It's a cousin of a drug we use commonly in other cancers like lung cancer and breast cancer. And you're right, I should have it on here actually. It's usually thought of as a second line treatment for typical adenocarcinomas of the pancreas. So yeah, it's another option. You're absolutely right. Yep. Yep. But all of these, the goals are the same. Unfortunately, I wish I could tell you, except for lymphomas, which many times can be cured with chemotherapy, unfortunately, the vast majority of pancreatic cancers, these drugs, even though they can have tremendous benefit for some patients, still can't cure the problem. And the hope is that we're going to have expanding options, and the hope is that if we use them in certain patients, there'll be a true benefit. But many times there isn't, and that's the hard reality of this. We talked about this a little bit, and maybe we won't belabor it because we'll have more time for discussion. And again, historically, this last little topic, historically, pancreatic cancer has been an orphan. You know, it's been resistant to all treatment. There has been very little advocacy. There has been just essentially no attention paid to it. Again, that's the honest truth, you know, until probably about 5-7 years ago. But now with some of these organizations, including Craig's Cause, and I could fill this whole slide now with the number of organizations involved in pancreatic cancer research, things are changing. It's slow still, but I think that more than ever, the next 10 years is going to bring a lot more options for this disease. So we all subspecialize in certain areas. So for instance, for me, it's breast cancer and pancreatic neuroendocrine cancers. And there's always more than one oncologist for each specialty. So the patients, the referrals that we get are triaged or sent to the group who deals with, let's say, colon cancer. And there are 4 of us who take care of patients with colon cancer. In that group, the patients are just assigned, you know, A, B, C, D, A, B, C, D, and just in rotation. And that's who usually ends up seeing the patient. Now, but there are cases where the relationships don't work, or and usually it's a relationship issue more than anything else. And patients can get second opinions. So for instance, I've had, many times what happens is it goes through the family doctor, and the family doctor will send a re-referral or a new letter, to one of us. It's difficult because, and every center is a little bit like this, and especially in a small place. And although Halifax is big, it's a small group dealing with these kinds of cancer problems. Just in terms of pure distribution of patients, we can't have just all of them going to one person. It just wouldn't work. The whole system would grind to a halt. So there is this distribution, but I guess the bottom line is that, you know, it can happen, no question. So the patient, and they can go, and most patients do feel intimidated. You know, to be honest with you, it's very difficult, right, to tell. I mean, I feel the same way. But you know, many times they'll go back to the family doctor and say, you know what, that just didn't work for me, and is there any way? And the family doctor will almost always. But the other thing I would say, to be honest with you, is sometimes it's a bad day. You know, we all have our bad days. And many times we all work with a primary care nurse. So again, you guys know Helen, right? So all the oncologists work with a stable single nurse typically. So many times if there are issues, and the patients feel much more comfortable talking about it to the nurse, and if the nurse can't help negotiate that, then it can go back to the family doctor. But many times the nurses will come up and say, listen, you know, it didn't work with us today, and I'm not sure it's ever going to work, and can you guys take over this patient's care? And so there is this informal way, And so two good points. One, excellent you brought that up, because yeah, the surgeons would definitely advocate. They have no qualms, you know, so that's for sure. And the second is, I think the history of it, you know, with surgical oncology, it often is an issue of what risk a surgeon thinks is reasonable for a patient, or can I get around that little blood vessel? And some are technically very good, some are less technically good, and they recognize their limitations. Some have huge volumes, some have lower volumes. So a lot of technical things that I think over time has evolved, that surgical oncology said, yeah, if you think this guy, this surgeon has better chance, sure, go for it. In medical oncology, it's oftentimes different. It's not so much a technical, you know what I mean, finesse issue. It's more of a communication style and exploration of options, and it's sometimes it's more what risk an oncologist thinks a patient might accept, and how much we perceive that through our lens versus the patient's lens. So it's just a totally different area of specialty, I guess. And this is one of the big differences between surgical oncologists and surgeons in general and other oncologists. So for many surgeons, if they can't remove everything, they are, and I'm not saying the surgeons you're talking about, it's just, we can't do anything for you. It's just a very blanket, open and shut, we can't do anything, go home, that's it. Whereas, you know, in medical oncology, we understand that many times we can't get there in terms of complete removal of everything. But exactly what you said, I mean, quality time, which comes in all kinds of flavors, is so important. One of the things we try and avoid, though, is making quality time one misery after another. And that's a problem with how difficult our treatments can be sometimes. But I think if patients are informed, and it's not just giving drugs and letting patient go and saying, just call us if you need us, lots of monitoring, lots of adjustments. Some patients tolerate everything we do very easily, others have a very difficult time, but we're almost always able to make it better. We're always able to manage one way or the other. And if things do become too difficult, you know, we do tell patients, you know, this isn't for you because it's just, your life is miserable despite everything I'm trying to do to help you. So it's very individualized. And the other thing is that it can always be stopped. If a patient, you know, asks and wants to try it, and if it's not for them, and if they hate it, they've tried it. And it's not something you can't, it's not, I always tell you, it's not a train you can't jump off of into another car. You know, we just, you know, the statistics will show us that almost all our treatments for pancreatic cancer, for typical pancreatic cancers, if you just look at the numbers in terms of shrinkage or time of stability, they're very small. It's very difficult. And so if we treat 20 patients with something like gemcitabine or Abraxane, our hope is that 3 or 4, maybe 5, will have prolonged control of the disease with minimal side effects. But we also know, and this is the dilemma of what we do, of that 20, 15, the disease will still progress, or they'll have terrible toxicities, and so that's why it becomes not one size fits all, not one treatment for everybody, and that's where the discussions become so difficult. You know, for a surgeon, it's there's a lump, either we can get it out or not. For us, it's uncertainty after uncertainty after uncertainty. So what I would call this is exactly what you guys just said, dormant. So one of the goals of our treatments is to try and put cancer cells to sleep. Because people can look like, you know, and feel perfectly fine, even with cancer still in them. The key thing to stop it from growing. So if we can stop it from growing, shut off that growth pathway, we turn it into a chronic condition. It's not quite remission, because when we say remission in cancer, we think of disappearance. But I think that recently there's been increasing awareness that there are subtypes, whereas before it was all one big black hole, to be honest with you. Whereas for breast cancer, we've known for decades there are different types of breast cancer. But again, because of the lag of research in pancreatic cancer, it's only now that really all these subtypes and all these differences are starting to become appreciated more and more. It's a big problem.
Are you involved in any clinical trials now?
Yeah, I'm actually director of our clinical trials unit here, and so we have a couple of clinical trials open for actually neuroendocrine cancers of the pancreas and others. But we don't have anything open for the adenocarcinomas of the pancreas at this point. So our neuroendocrine trial is through the National Cancer Institute of Canada, which has linked with one of the big American, what we call academic groups. So clinical trials can be either run as from an industry point of view, so a drug company, or it can be run as an academic trial where things like the National Cancer Institute of Canada or the National Cancer Institute of the States funds it. So different trials, they open and close. There are always trials opening and closing for accrual. Sometimes, and they typically come in waves. A couple of years ago, I had 3 pancreatic cancer trials on my desk to try and decide what made most sense for patients in Nova Scotia. And then other times there's nothing for a year and a half, and all of a sudden there's another new wave of trials that open up. So it's very strange. I can't quite explain it. Funding is always an issue, not so much for, it's a very long, complicated, long-winded story here, but the trials unit is 18 individuals who run trials, our nurses, our administrators, our data managers, regulatory folks, none of which receive funding from the hospital or from the cancer center. So a lot of the funding comes from actually funding from the trials themselves to sustain the trials unit. So and the bottom line is we're not limited in the trials we can open, but we have to balance the budget. But that in itself doesn't preclude us from opening trials. So it's a long-winded answer, but the funding, there's always funding issues constantly, but we can still open the trials we need to open. So it's a crew, it's called the Atlantic Clinical Cancer Research Unit. So we run about 25 to 40 clinical trials at any one time for all the solid tumors, breast, colon, pancreatic, including both radiation oncology trials, surgical oncology trials, and medical oncology trials. So yeah, I mean, donations can come through the QE2 Foundation, and we've reached. I know the efforts from this group have been towards directing individual projects, research projects, I think, and that's great. That's great. We need to get better sponsorship from the hospital itself. So yes, individual donations, great, but.
Is there any new therapy that looks particularly promising to you? Yeah,
there are. There's a treatment called the Mech inhibitor, which targets a very specific protein that we know is abnormal in a number of pancreatic cancer cases. But you see the research, so what's happening now, it's not just we find a drug and we just throw it at the disease. We start as looking at the disease itself and finding out what's gone wrong. And we try and design a specific something that's going to restore that wrong. And that's where the future is. It's not just taking a drug and throwing out the disease, it's learning more about the disease and then designing drugs. So yeah, there are a number of different options, but they're still quite a ways away from really making a dent. So radiation can be very helpful in a couple of ways. The first and the easiest answer is if cancer is spread, particularly to someplace like bone, and it's painful, radiation can be very effective at eliminating the pain. Doesn't get rid of the whole cancer problem, but it targets the pain. Sometimes radiation is used for skin issues, so cancer growth on skin when there's a fixed point. Where radiation is sometimes used with pancreatic cancer is in patients with disease that's all within the pancreas, can't be removed, is causing pain or symptoms, and so radiation can be given directly to the pancreas to help shrink things and take pressure off the nerves. So the problem with radiation in the abdomen, it can cause a lot of side effects because the guts are in the way. There are a lot of things in the way. So it's used, but it's very carefully selected patients because obviously you don't want to make things worse than they otherwise are. But radiation is changing too. So whereas before, radiation, you just literally draw a line, draw a box in the abdomen and just aim. Now they're much more able to target. even something like the pancreas. So even that's changing. And with all the parking issues that are going on, the radiation bunkers, we're going to have absolutely state-of-the-art machines that are going to help target radiation even more clearly. So likely there'll be more patients actually having radiation for this, because it'll just be more targeted. So I've had certainly patients who have lived for up to 2 years, 2.5 years with no treatment, and with good quality, with really minimal to no symptoms until the very end. And then you have patients that with same diagnoses, the cells look the same under the microscope, but who have just a cascade of problems and can pass away in a couple of months after the diagnosis. Because the problem with pancreatic cancer is the cancer itself, but also is the secondary effects. So it can cause an increased risk of blood clots, of infections. If it causes a lot of weight loss, people get malnourished. That increases the risk for other problems. So sometimes it's not so much the cancer growth itself, but the secondary effects of the cancer. And again, everybody's different. So it's really variable. But, you know, for every new patient I see, I can never tell them what's going to happen. And that's just, anytime you hear an oncologist think they know, I know what's going to happen, just walk away, because they don't. We don't. We're fooled all the time. There are great surprises. There are terrible disasters. There are, you know, and things can be going great, and there can be a sudden problem, or patients who you think, you know, have no hope of any benefit from anything can be, you know, so yeah. And I think that's more and more. It's going to be, you know, the new therapies. They're not coming from typical chemotherapy. They're all designed very differently, so that, you know, what was true 10 years ago even, and still today for some patients, no question, it can be just hell, you know. But more and more patients are walking around out there on chemotherapy or on targeted therapy or immune therapy. You'd never know there's a thing wrong with them. So that's the future. It's no longer this blast everything chemo and get everybody as sick as dogs, you know, in the hopes that you're helping one person out of 20. That's not acceptable anymore for anybody. It's really targeting things properly. And we're just learning to start to do it. So hopefully you'll never have to make that decision.